Welcome to Academy of Ultrasound's echocardiography course. I'm John Sheldon, one of the instructors, and tonight the lesson's going to be on Echo232. We're going to be discussing week 2, which is chapter 9 in comprehensive adult sonography, number 2. Tonight we're going to be starting the conversation talking about pericardial constriction, and it is a relatively uncommon entity. Clinical signs and symptoms are often vague and have been present for several years to decades before the diagnosis is established. The classic form is calcific constriction secondary to tuberculous pericarditis. Commonly in today's practice, constrictive pericarditis may be the result of infectious or inflammatory processes such as connective tissue disease or radiation therapy, or could develop several years after cardiac surgery. Constrictive pathophysiology can follow virtually any form of pericardial inflammation. Anatomically, constriction occurs when there is stiffening of the pericardium. Parietal pericardium that becomes the constricting force seen in association with pericardial thickening. The pericardial space between the visceral and parietal pericardium may appear filled with a vague echo-dense substance. You'll notice over here on the left, this is figure 929 from your Feigenbaum book. And this area that you see up here that's filled with the echo-dense substance is what we're referring to, this area between the visceral and the parietal pericardium. If you go down and look at figure 930, and you should be aware of both of these figures because you will see them on your exam. This picture up here, the black arrow indicates the external boundary of the left ventricular apex. The white arrow denotes the position of the parietal pericardium. There's a combination of free fluid and organized inflammatory material. This material in here, this echo-dense material, is not free fluid like the black area, but that's what they're referred to. That's organized inflammatory material. So in classic calcific constriction pericarditis, the pericardium forms a rigid shell in which the cardiac chambers are encased. More commonly, an elastic constriction occurs. Variable transmission of interthoracic pressures to the intercardiac chambers, pathophysiology similar to those seen in tamponade may be noted, such as, if you remember back from the tamponade section, you have respiratory variation in the mitral and tricuspid inflow that changes with inspiration versus expiration. So your echocardiographic diagnosis requires a combination of clinical and echocardiographic findings, no absolute sensitive and specific echocardiographic or Doppler indicators. Instead, multiple clinical, anatomic, and physiologic observations must be combined to establish the diagnosis. So we cannot simply do an echo and say the patient has constrictive pericarditis. Most often associated with thickening of the pericardium, actual detection is often difficult with transthoracic echocardiography. If the effusion is also present, the thickness of the pericardium may be directly visualized by echocardiography, previously mentioned on figure 914, page 253. So let's scroll back up here to page 253 real quickly and look at figure 914, and we can cover that real quickly. Your normal pericardium is no more than 1 to 2 millimeters in thickness. Ultrasound shadowing may occur. All right, so let's go back up here to figure 9-14. That's 918. Let's go back up here to 9-14. Bear with me just a second. It's taken a few minutes to get through all these pages. So 9-14. You can actually measure the pericardial thickness is approximately 2 millimeters. The pericardium is over here where it's got the little line in between the two effusions. In between the pericardial effusion and the pleural effusion, this line where it says pericardium could actually be measured, and it should be no more than 1 to 2 millimeters in thickness. If it's greater than that, then we have an issue. Okay, so moving on. M-mode abnormalities, abrupt relaxation of the posterior wall with subsequent flattening of the endocardial motion throughout the remainder of diastole, and abnormal septal motion, figure 931 and 932. So figure 931 on your left-hand side, this patient has constrictive pericarditis. Note the flat position of the posterior wall during diastole after initial rapid filling. And note the abnormal motion of the ventricular septum where the double arrows are. So you have the flat position of the posterior wall during diastole, and you also have the abnormal motion of the ventricular septum, this area where the two arrows are. That's indicative of constrictive pericarditis. So you have early diastolic notching may be seen, followed by paradoxical and then normal motion of the ventricular septum. Paradoxical, moving out of order. A wavy pattern of diastolic septal motion. Wavy, these two bumps. In elastic constriction, there's exaggerated interaction of the right and left ventricles, exaggerated septal position shifts with respiration. You'll notice in this particular figure, 931, it's a very straight and common or very uniform motion across. Everything's the same size. If these gaps in between the septum and the posterior wall change size with respiration, exaggerated interaction of the right and left ventricles with exaggerated septal position shift with respiration, so as the patient breathes. Noted both on M-mode and two-dimensional echo, resembles septal motion abnormality seen in cardiac tamponade. Let's talk about figure 9-32, sorry. This is a patient with constrictive pericarditis. This is a patient with a long axis view. In the real-time image, which obviously you can't see at this point, but the real-time image, this particular patient, you would be looking the subtle abnormal motion of the ventricular septum in both diastole and systole. So statically it looks okay, but the real-time image is where you have to pay attention to it. So let's go down to 933, which it refers to looking like the classic tamponade, has exaggerated septal position with the respiratory cycle. In the static image, note the normal geometry of all four chambers. But in the real-time image, which you should be able to find on your DVD, note the exaggerated shift in position of the ventricular septum with the respiratory cycle. Interventricular septum, here in the middle, is going to exaggeratedly shift during respiration. And a final indirect sign is dilation and lack of respiratory variation of the inferior venal cable diameter. This is your vena cava, your IVC. You have a dilated inferior vena cava and no respiratory variation. So you have no, when you perform the sniff test, there is no collapse. So your Doppler findings for constriction. Your classic Doppler findings are exaggerated E to A ratio of the mitral inflow, short deceleration time, exaggerated respiratory variation in E-wave velocity. So let's look at 3.5. Here's 3.5. This is a mitral inflow with a patient with constrictive pericarditis. You have an inappropriately elevated E to A ratio. You have a large E, smaller A, and a short deceleration time, which in this particular case they say averaged less than 100 milliseconds. Deceleration time is how you normally would affect or how you would measure the EF slope. The EF slope, the top of the E to the baseline, and it gives you this deceleration time and tells you how quickly the pressure is decelerating. Let's go look at 36. Number 36. You have a mitral on top, tricuspid on bottom, inflow with restrictive pericarditis or constrictive pericarditis. You have exaggerated respiratory variation of the E-wave velocity and the reciprocal relationship between the mitral and tricuspid flow. Remember from tamponade, you have an augmented velocity during inspiration and a reduced velocity during expiration for the tricuspid. An augmented velocity during inspiration and a reduced during expiration, compared with the reverse pattern on the mitral. Remember from tamponade, your mitral is reduced during inspiration and augmented during expiration. So again, it's exactly the opposite. Exaggerated respiratory variation is a relatively reliable sign of pericardial constriction. Emphasis on exaggerated respiratory variation in constriction will be seen during normal, quiet, non-labored respiration. A variation of 25% or more in the mitral E-wave velocity between inspiration and expiration have been considered abnormal. Most prominent when the patient is overvolemic, plenty of fluid. If the patient in whom constriction is suspected, repeating the Doppler evaluation after volume loading, if volume depleting, or with a head-up tilt if initially overloaded. Hepatic veins often reveal an expiratory increase in diastolic flow reversal. So let's go look at 937. You have your hepatic veins on the bottom. You have a marked respiratory variation in the mitral E-wave velocity on the top. And you note the marked early expiratory, when you exhale, reversal of flow in the hepatic vein. Let's look at 938. Again, note your hepatic veins. Respiratory dependency of forward flow in the hepatic vein with flow combined to inspiration and the reversal of flow during expiration. More elastic forms of constriction, systolic antegrade flow is increased with inspiration. Systolic antegrade flow is increased with inspiration. Emphasize that many of these classic findings may not be present in patients with significant concurrent valvular or myocardial diseases. Effusive constrictive pericarditis. It represents a combination of constrictive and tamponade physiology. Common causes are malignancy and radiation therapy. Patient will present with pericardial effusion. The thickening of the visceral pericardium may prevent right ventricular or right atrial free wall collapse, resulting in a decreased accuracy for the diagnosis of hemodynamic compromise. So you wouldn't have your typical collapse seen in tamponade. Diagnosis is often established in a patient with hemodynamic compromise and moderate pericardial effusion in whom jugular vein distension and hemodynamic compromise persist after pericardiocentesis. So they've taken out the pericardial effusion fluid, but they still have the respiratory and the hemodynamic compromise, leads us to believe that they also have constrictive pericarditis. After a pericardiocentesis, the effusive from the effusion component resolve, and hemodynamics appear more similar to constriction. That'll be it for this particular session. Once you've reviewed this, please be sure to review part 2 for the remainder of this chapter for this week. And also, you can go to Google and, as always, search for constrictive pericarditis images. You'll find plenty of videos, images. Please review them. If you find any that you don't quite understand, again, send them to john@academyofultrasound.com along with a short note, and I'll be glad to try to interpret them for you and give you some more experience so that you'll know what to expect when you go to take your registry and start working in the field. Good night.